All right, it's great to see everyone this afternoon. Um, as I said, my name is Mina McVeigh, and I'm the Director of Behavioral Health here at the Fellowship, and I'm a licensed clinical social worker. And I'm here today with Dr. Osborne. I'm going to let him introduce himself.
Hey, I'm Caleb. I am co-presenting. I am one of the assistant professors here in the addiction medicine clinic.
Great. Before I start, I wanted to make the comment that I changed the title of this presentation. It was Brief Behavioral Health Interventions in Addiction Medicine, but really what we're talking about are ultra brief interventions, things that you can do in 5 minutes. So maybe that will inspire you even further to stick with us today. So things that are not going to take up much of your time. So let's see here. We do not have any disclosures. So to start with, just remind everybody that in addiction treatment, as well as treatment for other mental health disorders, the best practice is pharmacotherapy plus CBT or another evidence-based therapy. So we are presenting here today some evidence-based brief therapies that would go along well with pharmacotherapy. They're also designed, because they're so brief, to be used in integrated care situations. That's what we practice here. They would work really well in a family practice clinic where you don't have a behavioral health provider. They would work very well in any clinic that has is not referring out their behavioral health. We know that integrated care reduces barriers to mental health treatment. It's one of the sad things about the world, that when we refer people to traditional psychotherapy, they rarely show up. But we know that medical providers are often in the best position really to provide behavioral health interventions, because almost everybody will see a behavioral health provider at some point. So just a reminder that what we're doing here is trying to reduce barriers to treatment in addiction treatment. So brief interventions versus coping skills. I wanted to clarify this because really brief interventions are coping skills. I have students ask me all the time, they tell us we need to teach coping skills. What are those? Well, they're brief interventions. They're one and the same. So I might use those terms interchangeably. When you're doing a brief intervention, you're not hoping to solve the problem for all time. That's not possible. But you are going to teach the patient to cope with or make some small changes that make their situation better. When you're thinking about these interventions or coping skills, you can think of them as interventions by diagnosis or symptom. So you might think these are interventions for depression, anxiety, or a symptom of depression. These are intervention for lethargy, or this is an intervention for insomnia. Or you can think about interventions in terms of just their intervention type. So interventions can be cognitive interventions. That means they address the thoughts that a person might be having that are causing symptoms. There are affective interventions, those that target emotions, feelings. Behavioral interventions, just exactly what it sounds like. Those are behaviors. You're trying to get the patient to do something different. And then somatic interventions are interventions that go directly towards the interoceptive experience the patient is having, the experience of their own body that they're having. And so you'll notice those different types as we go through this program today. Okay, in general, when you are, let's say, a physician or another practitioner that isn't trained as a behavioral health person, I have these suggestions for you. Don't teach something that you wouldn't do or haven't practiced. When you do that, it comes across as inauthentic. So if you are new to behavioral interventions, make sure that you think through what you're teaching first, so that you're behind what you're teaching and that you've practiced it, at least run through it in your mind, how you're going to explain it. Always use the spirit of MI, which is a spirit of non-judgment, openness, and curiosity. Ask permission before you offer any advice or any intervention. I usually just say, hey, would it be okay if we talk about some ways that you can decrease your anxiety? give choices. People don't like to be told what to do. They like options. So you might say, would you rather do this or that? We've talked about several things. Which one sounds best for you? So I always suggest that you have one or two interventions in your back pocket for each type of situation. Always encourage your patient to practice, and you can even practice in session. I highly recommend that if you have the time. Just brief practice, and then encourage them to practice and have them set a small goal, very, very small goal. Like, I will practice breathing 1 time this week when faced with symptoms of panic. And then the next time you see the patient, check back in. There's nothing that is more discouraging than a patient who does their homework and then you don't ask them. So make sure that you check back in and say, hey, did you practice that breathing strategy that we went over? And then one word of caution. Brief interventions, ultra brief interventions, are not a substitute for in-depth psychotherapy. And some patients with serious and persistent mental illness need in-depth psychotherapy. So don't believe that this is going to solve the problem for some of your patients that have serious bipolar disorder or other problems. You can still use brief interventions to help them cope in the moment, but they will need a referral for some extended care. So without further ado, I'm going to turn this over to Dr. Osborne to get us started. And Caleb, if you'll just tell me when to switch the slides for you.
Okay. Yeah, so like Mina mentioned, you can think of this as being by diagnosis or by symptom, and we have it broken down here a little bit more by symptom, or not even so much symptom as circumstance. So what the patient is experiencing and how they can add different tools to their toolbox. And you'll notice there is a fair amount of overlap. And that's one of the things that we really like to talk with patients about when we're educating them, just like we educate them about the medicines that we prescribe. You know, here are some realistic expectations for what your medicine can and can't do for you. Here are some potential side effects. We do the same with these tools. You know, I tell patients all the time, okay, you know, we're going to work on this breathing exercise together. I don't expect that you learn how to do box breathing and you're never going to have a panic attack again, right? And so teaching, you know, realistic expectations for a lot of these is important. But it's also helpful for them to know that there is overlap in terms of what tools can go with various situations. So urges and cravings are a very, very common issue within addiction medicine for our patients who, whether they are continuing to use and urges and cravings are what are, you know, leading to their continued use, or if they are currently abstinent, but they still have ongoing urges and cravings that are causing emotional distress or causing them to doubt their recovery, things of that nature. So with urges and cravings, so we can identify the trigger. So that's just a little bit of awareness or mindfulness, not necessarily mindfulness as a practice, mindfulness in the very broad sense, right? Being aware and mindful of what's going on. Urge surfing essentially is psychoeducation for, okay, this urge that feels like it's overwhelming and it feels like it's going to be there forever. If we can just roll with it for a little bit and avoid using while we're having intense cravings, the cravings will go away eventually. Self-soothing is a technique where patients essentially will identify sort of this heightened state. And then there are various techniques that they can use to help to soothe themselves. Distraction is I would argue probably the most commonly used coping skill out of all the ones that we'll talk about, just because it's very natural. It's human nature. A lot of people are very good at distraction, often to the point that they will, you know, when they lean too heavily on distraction, it can be an impediment, but it's a very natural thing. And then social support is very, very important. So I'll talk about a couple of these a little bit more in depth. So urge surfing, again, is the idea when we think of urges like a wave. They start as small swells and then they grow and they get larger and larger to the point where it feels like there's nothing else, right? I'm never going to feel any other way except for what I'm feeling right now. And so part of this is psychoeducation. So it's not even necessarily a separate skill in terms of here's what you need to do when you are having urges or cravings. A lot of it's just psychoeducation on, this is going to pass. It doesn't feel like it's going to pass, but it will pass. And so a big part of urge surfing is working just on some refusal skills and on some ways to even delay. And and then the craving will diminish. It will go away. It will come back, right? And so it's a continual process. One of the things that I will do with patients that is, it's a behavioral tactic that's really just delaying when we talk about urge surfing. It's a very common one that I will use for patients who have a tobacco use disorder, is delaying. And so what we will teach them is that when they are having a significant craving for tobacco, to set a timer. You can set it for 10 or 15 minutes, 20 minutes if they can handle it. And then you tell yourself, right? It's very simple. That's the idea behind most of these. They're not necessarily easy, but they're simple. So the idea is you're having a significant craving. You set a timer and tell yourself, I'm not going to smoke a cigarette until this timer goes off. And then the timer goes off. And what they'll find a lot of times is that the craving has diminished, sometimes to the point where they don't want a cigarette anymore. Now, right, nicotine being such a fast acting substance, there's going to be another craving likely pretty close to it. But once they get past that initial craving, a lot of times they'll find that's diminished. And there tends to be pretty good positive feedback loop with something like this, because when they get on the back end of it, they realize, oh, that did go away. We'll also talk about distraction a little bit. This is one that you don't really have to teach most people. I find that it's one that people tend to lean on a lot. And so when I talk about distraction with patients, I actually use it a little bit more as cautionary in that, hey, don't just zone into the TV for 8 hours a day trying to distract yourself, right? It can be a very useful tool. And it's one that a lot of people lean on very early in recovery, particularly before they've gathered other tools. But it is one just that works really well for a lot of people. Okay.
One final thought. A good way to distract yourself is to substitute another behavior for the use behavior. So that could be putting a piece of candy in your mouth, for example, instead of smoking a cigarette. So that's what that means. Okay, Caleb.
So for return to use, this is a very common event in recovery. You'll hear a lot of times within the recovery community, relapse is part of recovery. I would have a couple caveats. One, we tend to not use the term relapse. It's not necessarily a bad term, but there is a particular stigma associated with it. We call it a return to use. And the other caveat that I will give people is I will say return to use is usually a part of recovery, right? That doesn't mean that it has to be. There is a subset of people who try to quit and they quit and they're abstinent for the rest of their lives. But the understanding is that that's not most people, right? So return to use is a generally expected part of recovery. That does not mean that it's a mandatory part of recovery. And so dealing with a return to use can be very difficult, particularly if people have a significant amount of time abstinent, because a lot of times they will come back very distressed. They feel like, all this hard work that I've been putting in has been wasted, and I'm right back to square one, which is a little bit of I think AA and NA have done a lot of great things for a lot of people, and I recommend them to people regularly. But part of that mindset, I think, does reinforce, you had all these chips and you've got, 2 years in, and then you have a return to use and you're right back to day one. And so I think a lot of people have done well with that. And again, like I said, I regularly recommend AA and NA to people, but I also like to remind people, like, okay, so you've had 2 years abstinent, you've built all these skills, your life looks very different than it did 2 years ago. You had a return to use. We're not back at square one, right? And so one of the things we'll do is we'll do what we call a postmortem, which is basically we dissect the return to use. We look at what sort of things were you feeling? What was the situation that was happening? What were your thoughts and emotions surrounding that? How did you come to the decision? Because typically the actual decision to return to use happens well before the episode itself. Um, and we'll talk a little bit more about this later when we talk about identifying feeling words and things like that. And you'll notice as I talk, a lot of these are based on CBT principles, but brief interventions are not CBT. So this is something that we'll do where we look at, okay, what was the situation? What were your thoughts and emotions around the situation? How did that lead to the use? And a lot of times we'll come up with, it's rarely one thing, but we'll come up with a couple things and then we can problem solve. So the postmortem leads really well into the problem solving where we go, okay, you feel like you had to return to use because you were feeling lonely, right? You were feeling lonely because you live by yourself, whatever has led to the situation. And then we'll problem solve. Okay, well, what are some ways that you could feel less lonely? And a lot of times this leads very well into further connection, which is a skill in and of itself. And so the postmortem and the problem solving really go hand in hand pretty well. And then also we talk about harm reduction strategies. And so, okay, you've had a return to use, we've treated your hep C, but then you had a return to use of, IV meth. So here's what we're going to do to follow up on, okay, have you been re-exposed to hep C? Here are some ways where you can, if you're going to continue to use, the goal is we take this one-time return to use and we try to avoid it in the future, but we also live in the real world where people continue to use, right? And so we talk through, okay, are you using clean needles, right? How are you, like, walk me through step by step how you are injecting what you're injecting and what are some, this is essentially as though, right there, we're doing quality control. It's not what it is, but it's a similar process where you're walking through every step of the process and you're saying, okay, where are some areas where you're at higher risk for introduction of bacteria, you're at higher risk for introduction of hep C, HIV, and we minimize those risks. And the same can be said for, it doesn't have to be IV use. That's just kind of the low hanging fruit here. But any kind of use that they have, we can talk harm reduction. Okay, let's work on abstinence again together, if that's your goal, right? Let's work on the abstinence together. And in the meantime, let's talk about how we can make you as safe as you can if you continue to use. So
yeah, I've had a lot of success with harm reduction strategies, especially with patients that are feeling a lot of shame over their return to use. I will actually ask, what harm reduction strategies did you use? Because that gives them an opportunity to brag on themselves a little bit. So I might have a patient say, well, I didn't do any shots of liquor like you suggested. I just drank beer. And so that gives us an opportunity to engage in some real encouragement and to use some motivational interviewing techniques. So I really, really like harm reduction. Okay, one of the most common complaints that every physician or other provider is going to hear is, I'm stressed. And sadly, the population doesn't really understand what stress is. They like to use it for just about everything. The second thing they like to say is, I'm anxious, and we'll talk about the difference between stress and anxiety in just a minute. So one of the first things that I'll do is just provide some psychoeducation about stress, that there's a difference between eustress and distress, and that demands are really an important part of life, that if we didn't have any demands on our life, we wouldn't get out of bed. Um, Gravity is an example of a demand, and it's a stress, but we need gravity to get along on planet Earth. So I oftentimes will talk about use an overload metaphor depending on my client. I use a variety of different overload metaphors, but sometimes I'll talk about, you're a truck and you've got a heavy load, and you can either pump up the tires or you can offload some of the stuff that you're carrying. So just the concept that stress is overload. It is demands that exceed resources, and helping people understand that's what stress is in itself a really important intervention. Secondly, help the patient identify exceptions to stress. And this is something that you can do for almost any complaint, is when is the symptom not there? So when is stress not present in your life? You can learn a lot about a patient if by asking them when the symptom is not there. Because most people have some resiliencies, they have some coping strategies. Not everything in their life is horrible 100% of the time. And so that would lead into a conversation of how can you do more of that? How can you do more of what helps? So a person might say, you know, I'm never stressed when I exercise in the morning. It just really helps me. And then we talk about what's preventing you from, you know, getting regular exercise, if that's what helps you manage your stress. So you never know what a patient's going to say, but you just go with that. Another technique is self-soothing that we've mentioned before. I wanted just to say here that self-soothing in general is a somatic intervention. We think of self-soothing as being body focused, whereas we think of distraction being more mental focused, mental distraction, mental focus. So self-soothing is anything that makes the body feel better. Anything. And you can ask them, what helps you feel better? Someone might say, I take a hot bath. Well, let's do more of that. On a regular basis for chronic stress, for example. If someone prevents for acute stress, you might want to do an intervention in session. And progressive muscle relaxation, I'm sure you're all familiar with that, is a very quick and easy intervention to do with your patient in session. And then you can give them a handout that reminds them of the steps to progressive muscle relaxation and encourage them to do that at home. Many people have never done those kinds of exercises. I do encourage you to do progressive muscle relaxation with yourself first so that you understand the script. So we do that kind of role playing in our didactic sessions. As I mentioned, distraction is a cognitive technique, and the two most overused coping skills are self-soothing and distraction. Caleb hinted at that. But in an emergency, distraction is good. It's also good when you cannot control the source of your stress. So a good distraction that many people engage in, healthily and unhealthily, is gaming. So playing games on their phone or their computer. But any activity that they do that takes their mind off the thing that they can't control is going to be helpful in reducing either acute or chronic stress. The caveat is you don't want it to turn into avoidance. And then problem solving, my absolute favorite coping skill. It is the only one that actually eliminates the source of a symptom. And my encouragement there is that you problem solve on paper, and you problem solve with, but not for the patient. So the basics of problem solving strategy, and there is some research, our librarian can find some of that for us. A brief problem solving strategy has got a lot of evidence behind it, especially in primary care. It's really easy for physicians and other providers to use. You basically brainstorm without judgment any possible solution to the problem that the patient has, and that includes ridiculous or hilarious solutions. That actually is helpful in relaxing the situation. So you just get it all down there, and then you just take a minute or two, write them down, have the patient write them down, and then you say which one of these seems like it would be the best to try. And then their homework is to go home and implement one of the solutions, and they come back and you ask, how did that work? And if it worked, great. If it didn't, you go into problem solving part two. So this is one that you can use with many symptoms on a regular basis until the patient gets the idea that they do have some agency, that there are solutions to some of their problems, that they don't just need to soothe or distract, but they can eliminate the stressor. Caleb, any thoughts on that?
Nope.
Okay. Next, the second most common thing that we see is just general emotional dysregulation. And I'm not talking about a manic episode. I'm talking about just generally upset, crying, tearful, angry, irritable, that kind of thing. Similar interventions. Awareness is always the first intervention. Identify the trigger. What is it that's got you upset today? And if you're pressed for time, you can even say, let's take just a few minutes to identify what has you upset today, if they haven't already told you. And then a very, very simple way to help a person is just to help them match a specific feeling to the internal experience that they're having. The evidence shows that when people have specific feeling words for their internal experience, that they become more regulated. A lot of people only have two words, sad and mad. And that's not really very helpful in identifying what's going on. So you might, I actually have a list of feeling words that I keep handy, but you can also just guess. And they say I'm really upset, I'm angry. And you find a little bit about what's going on, and you discover that what they really might be feeling is disappointed. So you offer that as a suggestion. Sounds like you're feeling really disappointed. And right away, the patient will nod and go, absolutely disappointed. As much as I worked to help my child get into college, and then they decide not to go, you bet I'm disappointed. And just by validating their feeling, you have intervened and helped them to de-escalate and to feel better about the situation. Self-soothing, in particular, any grounding exercise, if a patient is upset, crying, simple breathing exercises. If nothing else, breathe in with your arms up over your head and breathe out as you bring your arms down 3 times. If you can't get them to do anything else, you might just suggest, hey, would it be okay if we take a few breaths? It usually helps people. Caleb mentioned box breathing. That's just a very simple breathing technique in which you're asking someone to imagine a box with equal sides, and they're going to breathe in, hold, breathe out, hold for the same amount of time. So that might be a count of 4, a count of 5. I usually ask the patient to find a comfortable count for themselves, because you don't want them to strain at holding their breath. And that's something that you can draw, they can trace it, and you can send it home with them. So simple box breathing. And then again, distraction for emotional dysregulation. If you can't do anything about it, what can you do today? Can you go for a walk? What can you do that might help you get your mind off the emotional upset? Caleb, anything else?
I put a link to the feelings wheel in
Good.
there
Excellent.
that can be helpful, just because as Mina mentioned, a lot of times people, when you're asking them to describe emotions, it's, well, I was mad.
Mhm.
So, well, there's probably something underlying that's a more specific word. So some of that, as she mentioned, just identifying it and validating it is the intervention in and of itself. Is, maybe I was feeling rejected,
Mhm.
right? Maybe I was feeling disappointed, right? Whatever it is, and the feeling can be really helpful in that process.
Yeah. The feeling wheel is a great handout to laminate and have handy in your exam rooms, or I have a clipboard where I have really common handouts. That's a real good one, or any other list of feeling words. Again, you're not just gonna whip out a handout, because that feels a little weird. To most people, you're going to ask permission. Would it be okay if we look at some words that help people connect to their feelings? Would that be okay with you? And almost always when you ask permission, they say yes, and they're more willing to receive the intervention. That's true for all handouts. Anxiety, probably the third most common complaint, oftentimes confused with stress. Let's see, Caleb, I think you were going to talk about this one. I've jumped ahead.
That's all right. Yeah, as Mina said, anxiety is not the same as stress, right? So stress is a normal part of human life, and stress, uh, when we use the word, a lot of times it's used with negative connotations, but that's not necessarily how it has to be, right? We don't grow without stress, and so it's a normal part of human life. So kind of validating that for people, like, yeah, you have a lot of stressful things going on. That doesn't necessarily mean that you need to be anxious. And so awareness is important. Again, as we said, there's a lot of crossover between a lot of these skills. Um, Looking for the exceptions, like Mina talked about earlier, it can be really, really helpful. Um, And then mindfulness, there are some good apps that use brief guided meditation. I know there was the Headspace app, which I think you have to pay for now. For a while, they were giving it out for free. There's the CBT so it's geared more toward insomnia, but they have a lot of brief interventions on there, even that can carry over into anxiety. They will walk through leaves on a stream, which is something that I'll do with patients with some regularity. Scheduling worry time can be a really helpful exercise for anxiety, for a number of reasons. One of those reasons is that if people are anxious, they're going to worry, right? So it's not going to be helpful to tell them not to worry. But one of the things that oftentimes people feel very anxious about is about all the things that are outside of their control, and anxiety can feel overwhelming, and like there is a huge loss of control. And so scheduling worry time can be helpful. You might say, okay, I'm going to worry about X, from 10 to 10:15. And yeah, okay, so you're going to worry about it, but to some degree it puts you in charge of it. It gives patients a little bit of that autonomy back. And then, of course, being realistic. Okay, so you worried about this thing from 10 to 10:15, but the thing you're worrying about is that you're getting evicted and you have nowhere to go. I don't necessarily anticipate that you're not going to worry about that the other 23 hours and 45 minutes of the day, right? Is going to pop up some, but it gives them a concentrated time to worry about it, and it puts them back in control to some degree. Exercise is can be a form of grounding, which we'll talk about. It's also behavioral activation, and so it hits a lot of those boxes. It can also be distraction. So exercise is an intervention that can do a lot of good things for a lot of people, just both psychologically, physically. And then also, I'll reiterate the looking for exceptions. This is really helpful because it can help people think through, like, oh yeah, I was feeling okay for a day or two this week. Well, what was going on then, or what was not going on then? What was different about those days versus all the other days where you said you felt overwhelmed all day? That can be a really really good. Looking for, think of it as medically, you look at review of systems, and you have kind of pertinent positives and pertinent negatives. And so looking for exceptions, it's kind of like getting those pertinent negatives for people. So that's all I had on that slide.
Okay. A few more things that I wanted to touch on here with the psychoeducation. I think my patients, when I remind them that anxiety has a fear component that stress doesn't necessarily have, is important. And that leads us down to the a conversation of awareness of what are you afraid of. That conversation can be a little bit longer, but then some. So if you don't have much time, you might not want to go all the way down that road. But there is a fear component to anxiety. I love scaling so much. Scaling is just asking your patient 0 to 10, how anxious are you today? And so if they say a 10, that's pretty bad. It either is a 10 or there are some patients that everything's a 10. And if you've been asking them all along and all of a sudden today's a 10, then that gives you a lot of information. But why I like scaling, and that's called a subjective unit of distress, is that you can use it as an intervention to say, so you're a 7 today. What do you think would drop it to a 6? Like, what small thing could you do to drop your anxiety from a 7 to a 6? And most patients intuitively know, they get what you're asking them, and they can come up with their own intervention if you just ask it that way. So I really, really, really like scaling. Apps, if it's really helpful to have the apps on your own phone. Patients love it when you whip your phone out and show them that you have the app on your phone. And they're more likely to try it if they see it on your phone, see the icon, see how easy it is to open up. I really like calm.com in particular. I think they do have some free content, but I mean, you may have your own favorite ones, but I really do like apps. YouTube has a lot of free guided meditation as well. So you can pull up YouTube on your phone. So that's just a few other things I wanted to add there. Caleb, do you want to do panic or do you want me to, since I got ahead of you?
It doesn't matter either way.
All right, well, I'll
I
jump
think
in. Go ahead.
you probably do more of this in
Okay.
practice. So if you want to do it,
Okay.
it's fine.
All right. So with panic, especially if someone is actually having a panic attack in front of you, but even if they're just having them at home, what you want to talk to them about is rescue techniques. I found that language very understandable to patients. Is it okay if we talk about a few rescue techniques for you? Or if they're having a panic attack, you just go into the rescue techniques. So I like this 3-point rescue technique: breathing, tapping, shaking it off. So breathing, 3 deep breaths with your arms up over your head. Exhale, the arms coming down. Do it with them 3 times. Tapping, so the body, the body really responds to somatic distraction. So there are different places on your body that you can tap, but if you don't want to tap anywhere else, you can just find the edge of your collarbone and just tap with a finger. And that is a very soothing technique. It works similar to some of the EMDR techniques that use bilateral stimulation. When you're tapping with your right hand on your left clavicle, that requires your brain to cross over. And so that can be very effective. It's also very soothing. They can tap their chest, they can tap their neck. Most of them are very willing to try it. And then shaking it off is literally taking your hands and discharging some of the adrenaline that is surging through their body. That is what animals do in the wild. If they are able to escape the predator, they will go and they will shake. And you probably shake too. You've noticed it when you didn't have a car accident, but you almost did. You will start shaking, even though the danger is gone. So shaking it off is a really helpful technique. Breathing, tapping, shaking it off. I encourage them to do it. I do it in session. I'll do it a couple times in session. The 5, 4, 3, 2, 1 grounding. Again, if you have someone that's actually having a panic attack or they're dissociated and they've dissociated and you want to get them back, you can gently say, let's see if we can ground. Let's go with 5 things that you can see. And so they're going to open their eyes and they're going to look around. 5 things that you can see. Then you're going to go through this: 4 things you can touch, 3 things you can hear, 2 things that you can smell, 1 that you can taste. And this is also a technique. You can give them a handout and they can do this at home. So 5, 4, 3, 2, 1, easy to teach, easy to remember. Another rescue technique is after they've stopped hyperventilating, if they are, offer someone a drink of water. It really is a very relaxing activity. It gets them to swallow, gets them to slow their breathing down. So you might want to have bottles of water around. And then I love a weighted blanket. I have a weighted blanket, and whenever I'm having a patient that is really having a panic attack in session, we have one of these that we can use in the clinic that's about a medium weight. Most weighted blankets are scaled for the size of the patient, so don't use an adult blanket on a pediatric patient. And I just invite them. I said, do you think a weighted blanket would help you? There's a lot of familiarity out there with weighted blankets right now. You can buy them on Amazon. And so not only is it a good rescue technique in session, but it's a really good technique for patients at home to use for panic. Anything else?
I really like the breathing, tapping, shaking it off,
Mm-hmm.
and then the grounding technique. Just if you
Yeah,
have them
those are
grossly in order, you probably don't want to say, okay, tell me 5 things you can taste right now, because you're
no.
starting off on
See,
the wrong foot. But
don't do that.
yeah.
Yeah. Yeah. Yeah, so these are just examples of rescue techniques. You may have your own already. These take very little time and can be used for a lot of different symptoms. This just happens to be for panic, but emotional dysregulation, you can use these for as well. All right, Caleb, I'll let you take depression.
All right. So, when we look at depression, right, we have the symptoms wise, they're kind of grossly broken down into somatic and cognitive symptoms. So for somatic symptoms, the body based, right? So this is right, either insomnia or hypersomnia. This is just that like physical amotivation, right? Don't want to get out of bed, don't want to go out. I'm not enjoying the things that I used to enjoy. Some of those cardinal symptoms. Behavioral activation is a very broad term. But the idea behind behavioral activation is that a lot of times, so our bodies and our emotions and our feelings go hand in hand. And so a lot of times what you'll see is people get caught in this really, strong feedback loop where, well, I feel a little bit depressed. And so I don't think I'm going to go for that run today. And then not exercising makes people feel more depressed. And so now I feel more depressed and I'm mad at myself because I've made a habit of running and I didn't do that today. And so tomorrow I'm just going to stay in bed. I don't feel like getting out of bed. And it can be a significant feedback loop. And so the idea behind behavioral activation is we're going to choose to do things that we don't necessarily want to do in the hopes that our brain will respond to that activation and the feedback. And so this is a really helpful. One of the things that I like to ask people, because sort of that anhedonia or lack of enjoyment is a really significant symptom for people, and it can lead to a lot of the amotivation. I will usually ask people, because if you ask someone who is significantly clinically depressed, okay, what things do you enjoy doing? I don't know, nothing, right? So one thing that I will ask oftentimes is, when things are or were going well for you, what did you enjoy? And it's okay, go do that thing. Understand you're not going to feel like it necessarily, but really that's the general idea behind behavioral activation. Exercise, as we mentioned earlier, is one of these. But getting good sleep as well is important, right? So an appropriate amount of sleep. So this would be a good time to talk about sleep hygiene with people. And then some of the cognitive symptoms, scaling, as Mina mentioned. I oftentimes, when I'm using scaling for people, I like to use ridiculous scales. I don't like to ask them on a scale of 10. I like to ask them on a scale of 73, because, well, I guess this is just self-awareness. I tend to overuse levity as one of my skills. And so I think if you can make it silly, it can be a little helpful just to get people out of, kind of out of a more negative mindset, although sometimes it backfires. So you do have to be aware of that. It doesn't always work. And then looking for exceptions, which we've already talked about, identifying triggers and associated feeling words, and then problem solving, which Mina has already hit most of those pretty
Right.
well. And problem solving is great because it's the only thing that's going to help make the situation in and of itself better. So a lot of times people will say, well, okay, maybe I'm depressed, but it's just situational. And so there's a difference between adjustment disorder or acute grief, where the situation is time limited, as opposed to, well, I'm depressed because I'm homeless and I've been homeless for 6 years. And you go, well, okay, so what are we doing about that? Because if the stressor or the situation that's causing a situational depression, if it's going to be the same for the anticipated future, then the idea that they're just going to, magically feel better without a change in situation is, we're not really setting people up for success. So problem solving can be really helpful.
Right. Thank you, Caleb. For sake of time, I'm going to speed through these because, as you can see, a lot of the interventions are the same, and that's a good thing. There's not a magic bullet. They're the same type of coping skills are going to come up over and over and over. So getting familiar with the basics, and you can just mix and match. Briefly, adult ADHD in the substance using population, 25% of all patients with a substance use disorder have adult ADHD. They forget their appointments. So if you do anything with them, help them use a calendar or lists, or give them a pad of sticky notes and write the appointment on the sticky note and tell them to stick it on the back of the door. That intervention takes less than 2 minutes, if you have the sticky note already there, or even if it's in the next room. So these are very, very helpful brief interventions that make ADHD a whole lot more palatable for our population. Acute grief. Caleb, I'm just going to buzzsaw through these if you're okay. This is all about listening, normalizing and listening. Don't be afraid to talk about the deceased if it's grief due to a death. Grief can also be from any loss. It can be from the loss of a job. It can be from the loss of health, the loss of a limb, loss of many things. But encourage the patient to share their memories. If it's a loved one, maybe they'll show you a picture, encourage them to use some sort of a ritual to help them move through the grief. And then if sleep is a problem in grief, sleep hygiene or medication if necessary. Psychological first aid. Again, this is a brief intervention. Acute trauma, sexual assault. This is not the thing that's going to solve the problem of post-traumatic stress or help a person to get over or get through a sexual assault. But your job in an acute situation is to administer psychological first aid. I have a reference on the last slide that has a very good explanation of psychological first aid. In general, provide a calming environment, emotional support, help them with their feelings, listen, and if, again, problem solving. If do they need anything, what can you do? Can you refer them to case manager? Can you refer them to someone that can help them with the next step, whatever they believe that it might be. Interpersonal and family conflict, it happens, and people go to their primary care doctor and even their addiction medicine physician and talk about their family conflict, which causes a lot of return to use. If you were to ask what caused you to use, I had a fight would be top up there. So I always talk to my patients about the difference between healthy and unhealthy venting. So when you're listening, explain that healthy venting is using a regular indoor voice while someone is listening quietly, not getting activated again, getting upset, getting mad, hitting things. So you want to encourage and explain what healthy venting might be and ask if that would be helpful to them. Again, problem solving, we've talked about that. Boundary setting. This is a simple intervention that many of our patients do not even consider. Block the person on your phone. Temporary block them on social media. You'd be shocked at how many people say, "You mean I can do that?" And I'm like, yes. Just that solves a lot of problems right there. Okay, so we have gone all the way up to time because we did not have a case study for today. Caleb, last words from you, and then we'll see if anybody has a quick question.
I have no last words. I cede my time to the floor.
I do see we had one additional person join us, Jamie T. Would you mind unmuting and introducing yourself just real quick?
Hi, yes, I'm Jamie Taylor. I'm the EOP nurse practitioner at Alliance Healthcare in Memphis, Tennessee.
Awesome. Thank you. I'm glad you're able to join us. Well, thank you, Dr. Osborne and Mina, for that wonderful presentation. You have run us right up into time. So in the interest of getting these folks back to their days, I'd like to thank you all for attending. We'll be back in 2 weeks. I believe, Leslie, you can correct me if I'm wrong, but I believe Veronica will be talking about justice-involved advocacy. And if not, you'll see a link for something entirely different.
Let me bring that back just a second here. I think it is. Okay. I have it on April 3rd, and then March 20th, I think, is Dr. Meat.
Okay.
All right, I just posted it there.
Okay. Is March 20th our next one? Or
I believe it's March 20th. I think they're taking a break.
Yeah, we had many cancellations, so we decided to go.
We are taking a break then. It will be March 20th, and we will see you all then. And if there's anything else, we will send out an email and let you all know. Thank you all for coming.
Thank you all.
Bye-bye.